Welcome everyone to the Couple Podcast, episode 114. Man, episode 114. It's been such a long time.
It has
It's been
been.
super fun. We did a bunch of episodes like on a roll, and I was thinking back at it, not to get off topic right off the bat, but now like when I said 114, like we've been podcasting and travel nursing for a minute, and we started like podcasting and travel nursing in Oakland a few years ago, and we made like a on the go podcast.
And if you watch like the episodes 40s, that's what it's there. We're like in the second story, and it's like a hood neighborhood in the back. We're just podcasting. There's stuff going on in the back, like there's cars, there's people walking, riding their bikes. It was really cool to capture.
Yeah, like the progression of events of like our environment behind us that we recorded. It started in your room, right, in your condo,
And it was super tight. We could even barely walk through. Small little chairs, table from IKEA that we built. My dad had to put like weld something together so it could be raised to 6 inches just so we could fit.
right, and then the whole green screen we had over Matt's wall, and then after that, our next stop was basically Oakland, right, and that was like two different environments. We tried one with the green screen where we tried to make a makeshift green screen over a window, didn't work out very well, and then we just decided to drop that idea and concept and just use the window as just like the backdrop or whatever. And
That was
there's
a lifesaver.
yeah, and that was just like stuff going on in the back as you saw as like the sun came down, the streets got more filled with people. It was always interesting to like see our background because you have like a live background and there's people doing stuff, moving around, construction, house is being remodeled. So it was always interesting to take a look at what's going on, but it's super active. And then we went back to your place, and then we came here to California.
The progression.
Yeah.
Thank you guys for tuning in and listening and messing around with us for as long as you guys did for the real OGs that saw those videos. So today we're going to talk about the gross parts in nursing. We all have stories as nurses and the nastiest stories. And this is going to be regarding vomit, poop, blood, genitalia areas, just all together mixed up in this episode. I think it's not PG-13. It's like rated R. So if you're listening and there's kids in the background, I don't think this is the episode to be aired and played right now.
Yeah, ready G
Save
for
it for
gross.
later.
Yeah.
G for gross. What's the first one?
The first one is one that I've probably had the longest struggle with when I became from nursing school to a new grad nurse to actual nursing is respiratory secretions were always the worst.
I still hate them.
Yeah, like it took me a while to get over those. Like at one point, I would have rather dealt with poop than respiratory secretions. Now I totally flipped. Now I don't mind them anymore. But in the beginning, it was just so gross to me, and it was so hard for me to always suck at somebody's trach because that sound and that, like especially if it was like an opaque in color or it was like frothy and nasty, that was really hard for me to take in.
Likewise, trachea, sputum, worst parts. And recently, most recent shift, I had a patient that wasn't intubated, had a lot of secretions, so they put the nasal trumpet in. So I was deep suctioning him through that nair. I was suctioning him through the right nair, which had already a dub huff in. And then I was suctioning him orally to stimulate him so he could freaking not get intubated. And there was so much stuff coming out of all those orifices. Disgusting. When it comes to labor, poop is worse, right? You have to flip the patients and sometimes they poop again. But respiratory secretions are by far the nastiest. I just can't look at them. My mouth is just feeling sour just thinking about it right now. And sometimes it has that nasty smell. Like this guy specifically had E. coli. I had a pap around and you still just, ugh.
Damn, that's super nice. That's like the one thing that was really hard for me in like peds clinical with children, not infants but children, because majority of their issues and complications are with the lungs. So it's majority of my clinical was like suctioning, help with intubating and extubating, and just all respiratory. And that's why peds clinical was so hard for me. Not because it was the kids, it's because me and respiratory didn't get along. It didn't settle well.
Yeah, for me, my first patient care that I had in a real hospital as a clinical was a patient with a trach. And I was in the room alone, went to go do my assessment. I don't want to wait for the nurse. And I close the door and she starts coughing, like, they do that trach sound.
Yeah.
And I'm just trying to figure out what to do. This lady's eyes like open up, like wide open. And I'm just like, holy shit, I froze as a baby nurse. I don't know what to do. So I would run back and I didn't even assess the patient. I had to go get the nurse. So I know what to do. And so we had to like deep suction. And it was such a trip. Maybe that's why I find, respiratory secretions so nasty.
Yeah, not a good time. Not a good time. And it's crazy because the thing with suctioning is it's great, but over suctioning can be a lot worse. So I know at the prior hospital there was an issue because the suction was always on full blast
Yeah, we talked about
and you
it.
couldn't gauge it. Yeah, we talked about it a few episodes ago. So you couldn't gauge on how much suction is going, into the wall. So people would jam, especially with people that are intubated. They would deep suction and they would go fully in and hit the suction on full blast and then pull out. So they would hit an area in like the trachea or one of the bronchioles or whatever, and it would damage it, and then plus it would suction it out. So they're literally pulling tissue each time, and then people were wondering like why is it bleeding going on?
And respiratory knew about it. We couldn't do anything. The doctors sometimes knew about it. I told the physicians, and I just don't know why this hospital never invested into it, especially during COVID when they were fragile. There was so much tracheal bleeds.
Yeah.
And we were the causes of it because just like you mentioned, you're supposed to suctioning, I believe, like 60 to 80 milligrams of mercury. We're on full blast, like 200 plus, just like going through it. And the next part is like oral care has to do with the same thing, like respiratory secretions, nasty, especially the people that are like alcoholics, neglect themselves. Nursing home patients sometimes have mouths that like have food that are neglected, and you're just trying to like go through their mouth and it just not coming out.
you take out
Sometimes
chunks.
it's in their teeth and there's like chunks you could just literally pick with something.
Yeah, somebody's like this can get real bad when someone's not getting proper oral care. There's been times where I've took out pieces of like dry gunk, I don't know, leftover food or built up or something, and it's literally like almost an outlining of a person's side of their mouth. It's that big of a piece.
Yeah.
And it's just like like 3 inches. It's like what the hell, and you can see the indents of where it was under teeth. And it's like holy shit, how has that not been cleaned for?
Yeah, it's mostly neglected. I wish we do an episode about talking about pneumonia, and that's the reason why we do oral care. But there's a lot of like mouth care that has to do with the way our flora is behaving.
Right.
I know our buddy here that we live with, he has like the tooth depressor that he scrapes. I wonder what are the health benefits with those.
Yeah. Like if I know it gets busy, but you should at least do oral care at least once a shift. Just do it at least once.
For your non-intubated patients.
Yeah. Yeah. I mean, for intubated patients, some people don't even do it all shift,
I've noticed that too in a lot of hospitals.
I would
It
say-
gets busy and gets neglected.
I would say just don't matter what your patient is, just oral care once a shift. Straight business. That's that easy. Just devote it. I know you're supposed to do more often than that, but try at least get that one.
And also do it like after you give your patients applesauce and all that. I find that nasty when you're like looking for a pill and you tell your patient to open up, and then you open up, there's a bunch of old food just sitting in there. It's a nasty ass mouth. Just clean it up, ladies and gentlemen. Oral care after you give your patients meds is I would big.
Yeah. And then the next one on the list is going to be vomit. Man, vomit, dude, it's always interesting because when a patient's about to vomit, there's 2 outcomes. One, you're going to get the bad basin time and you're going to vomit in the basin. Or 2, patients going to vomit all over themselves and you got to clean them up.
Yes.
And it's like a 50-50 almost each time. If there's no basin in the room, you're like 45% chance you're going to come back in time.
It's funny. This is not a nursing story, but I actually had Peter's vomit all over my hands when you're in
yeah.
the ER in Arizona. I was trying to hold this damn bag. I don't know what it was. A garbage can I brought and just went all over my hand.
Yeah, I couldn't
trying
control
to catch
dude.
it.
Dude, that was crazy, man. I remember that. I went on my shoes, and that's when they realized the shit was serious, and it took me in. But besides the fact, vomit, it's gonna come in all textures, all smells, all sizes, all colors. Yeah, and coffee. You always taught in nursing school the coffee ground emesis. When someone has a GI bleed and they're vomiting coffee ground emesis, that's significant of a GI bleed.
And this has to do with like NG stuff too. Sometimes you're pulling stuff out of the NGs and it's bile, it's greenish, it's darkish. So you're doing a lot of that. It's nasty when it goes on your gloves. Sometimes nurses try to use NG tubes and they try to like wrap it into like a glove and it leaks all over the bed. That's the worst. Aside from like cleaning up, you sometimes feel guilty when you don't want to change your bed because you're rushing and there's like a little bit of not vomit, but maybe like a little poop smear on the sheet. You're just like, should I change it? Should I not? You try to take like alcohol wipe and clean it. Sometimes when it comes to vomit, it's so nasty when it leaks on the side of the bed, and then you have to clean the bed rails and everything. Grab bleach. I'm trying,
Or if it's
those are
like
nasty
if
stories.
it's just like your OG connected to a LIS, like lower limb suction, and you're just pulling out the gastric contents, and it's like brown or it's just like bile looking and there's so much of it and it keeps going. Or when they have upper GI bleed, that blood just pools there and it sits there and it gets pulled out. Like seeing an upper GI bleed like happen while you're, there was a patient that I had that was GI bleeding and I was basically pulling out his GI bleeding from the suction. That's how much it was GI bleeding.
So you're just suctioning it yourself? Just
No, like it was connected to the suction, like LIS, laminar suction.
Oh.
Yeah, but it just kept, it was bleeding continuously.
Just kept, wow, he kept pulling
Yeah.
it. That's disgusting.
I know.
It's like blood, Frankie
we were
blood.
pulling out blood, giving him blood, and before we had to do surgical intervention, man. Like, dude, it was wild. We would literally, it's like he was continuously bleeding and pulling that blood out while giving him blood at the same time. And nonstop.
Speaking of blood, trachs, I had this one case when I was back in Chicago that there was like this young 30-year-old that had to get a trach because he was so anxious and he was ETOHing and all that.
No way. Just because of that?
And I think he accidentally pulled his trach or he caused a bleed. So we had to have a stat ENT surgeon come in and we were literally holding his like, we had like sandbags, not sandbags, saline bags trying to pressure the wound. So there was a nurse that had to hold it. And when you undid the thing.
He had esophageal varice? Dude,
Not even esophageal varice, but he was bleeding somewhere on his trach and the ENT doctor had to cauterize his vein. It was just bleeding out of the trach like a little stream.
It was probably was an artery of some sort.
Yes.
Damn. That's intense.
I know. And that blood was just all over. The wildest thing is also, speaking of blood.
Was he swallowing the blood?
That was a COVID, I'm sure. I just forgot the whole story. It was so many years ago.
Damn.
There was a time that an ECMO nurse, or not an ECMO nurse, an ECMO perfusionist was in a hospital trying to switch the connectors, and the blood just shot out on her while she was connecting it. Something happened with the clamps, or the clamp failed or wasn't on properly. So imagine having a bunch of COVID blood all over her.
Damn, that's gross.
Yeah, I'm thinking of random stories. And going into vomiting, like elderly genitalia. That's another wild one. Is first story that I think of is that nun that was trying to put a Foley catheter and she had like
Bless that nun's soul.
Yes, man. R.I.P. Like she had like just vulvar cancer everywhere. Like I said, it was just try to put a Foley in, and there was like 3 of us in that room, and she was screaming. Oh man. And there's so much nasty genitalia. I hate when like I have to say it, the poop mix is in there too, and you have to like clean.
It's so like the grossest thing probably ever in a hospital is getting that patient that has not been taken care of properly, not washed properly, and there's like stuff growing there almost. You know, it's like white, it's like nasty, it smells horrible, and like you could tell that no one's cleaned this person in such a long time. Especially if they have like contractures and stuff.
Especially also when they're homeless.
Yeah.
So thinking of nasty, gross stories, I thought that respiratory secretions are the nastiest, but now I thought about it. You know what's nasty? Having a homeless patient's wound filled with maggots. And then imagine pouring like hydrogen peroxide on this wound, and then these little damp things are moving around.
You've had that before?
Yeah.
Oh man.
And the patient also had scabies.
Oh man.
So you're in there like in full. I still have that photo. I was completely like, this is pre-COVID, like gowned up with like the booties, the little heel protectors on top of the blue gown for precautions.
That's
that was
so nasty.
And ID had to go see her. Yeah, that's as nasty as it gets. Seeing live things literally eating a person's body because they're so neglected.
So when you put on the hydrogen peroxide, did those little maggots die?
They're supposed to.
But they don't always die, right?
They also use this kind of treatment. Well, this wasn't for the maggots, but this was... There's a special drug that you give for that too. But also you cream them down for the scabies cream. I forgot what it's called. Yeah. Just so it kills everything on the skin.
Damn. That's crazy. That's probably the nastiest thing that I've ever heard. I would top you for the story, but I can't at the moment.
No, it's okay. We're just sharing stories.
That's nasty. So that's nasty.
Yeah, and then speaking of genitalia, because we're nurses, especially in the ICU, when we get these patients at admissions, this is the first thing that we do. We have to assess every little orifice, everything about your skin. So we literally just strip you naked. And it's just so funny because we see so much naked people all the damn time. The elderly, because we deal with geriatrics, and Yeah, it's just so funny because they always just freak out at once. So you always have to tell them, okay, for the next like 5-10 minutes, there's gonna be a lot going on. There's gonna be a few nurses in. We're gonna put a bunch of leads on you, blood pressure cuff. We'll do assessment. We're gonna turn you. We're gonna put a foam on your butt. Just get ready, and it just happens. And it's
Yeah, it's always interesting when you have that patient that's like almost with it, or even fully with it, come to the ICU, because there's times where you're just going through the motions, and you're like, oh shit, I didn't even explain to this patient what I'm doing and why I'm doing it. So basically, strip these people naked sometimes without explaining to what we're gonna be doing and why. So imagine how shook they're going to be.
yeah, it's a
Like it's
culture
like
shock.
what's like what the hell's happening? But it's so natural to us, so normal to us. That's what we do. Like we want to see what we're working with everywhere.
All the time. And you know, it's also if there's non nurses listening, it's also the hospital's accountability to make sure that patient didn't come with wounds, because if there's a wound that's not documented because we didn't do a 4 eyes assessment, and the hospital is going to get dinged and they have to pay for that wound. Let's just say it has to get have a debridement. That's going to be the hospital cost. So it's really important for nurses to always check wounds and everything else, especially DTIs, nursing homes. They leave them with stuff on.
Yeah.
And, you know, speaking of genitalia, just overall, just the whole body. And that's going to go into like wounds. There's so many different kinds of wounds, and it's so nasty seeing them. One of which was during COVID, the most recent type of wounds. We call it COVID butt. And these patients, of course, were always on ECMO or CRT. They're just laying there, and their own pressure wounds built up. But something with COVID made the skin just peel off. And those just large areas, like their whole ass, sacrum, down to even the thighs, that just skin just slid off.
Yeah.
And they're just leaking. And we try to do wet to dries and zero form, and you couldn't put a wound vac in. Sometimes
You got chewed up somehow.
yeah, and then also in this hospital, speaking of COVID, there was a rectal tube that was inserted, and which caused the MTP, massive transfusion protocol. So ICU physicians were scared to use rectal tubes on patients. So we had this COVID butt on top of patients just shitting diarrhea, and then you're trying to wipe this wound that has poop all over it. You're trying to spray something to clean it, and it's not going to heal because there's poop from your gut microbe that just infected with healing tissue. It's so damn disgusting, and it's just something we had to deal with as nurses during that time.
It's so nasty. And what they don't understand is with these rectal tubes or flexes, these things are going to happen ever so often. It's not something that you could have prevented. She probably popped a hemorrhoid or something, like a really, really bad one.
Yeah, artery.
Yeah.
Yep.
And that nothing she could have done would have prevented it. Right? So why is it's like almost being punished for it, right? Because the unit probably could have prevented a lot of those COVID butts by having a cleaner environment.
Could have. Or also COVID just did that, where just the skin wasn't getting oxygenated because they're already hypoxic. The skin was dying and it was just sliding off, man.
Yeah,
and
true.
COVID butt was the thing.
Yeah. Yeah. And then these people were like leaking nonstop. So it's like you clean them up, half an hour later, same thing. It just leaks. Like there's no rectal tone. Nothing's there. It's just like a water slide.
And then, you know, aside from COVID butt, these patients, we had to like anticoagulate them because
I wonder if they could have done a temporary ostomy.
they could have.
You know, to redirect
But
for a little bit.
they're too unstable. Like these
True.
COVID patients were too unstable. OR wasn't a thing during COVID time. So colostomies and surgical procedures were like the least of these worries. Like everything was happening just in these rooms.
Right.
And what I was mentioning is these COVID patients, speaking of orifices, they were anticoagulated with heparin or Angiomax, and they were just bleeding all the time. We couldn't control it. The worst was when they're bleeding out of their mouth because they're intubated, their lips would crack, and they're just like profusely leaking out of their mouth. We had towels underneath their necks. We used to stuff their mouth with dressing, and it was just coming out. That was inhumane to see.
Yeah. It was just one giant experiment because nobody knew what to do. But we had to keep you alive. So we had to try every measure possible.
It's either you bleed like you did, or you had a clot and then you coded and we couldn't do anything. So it's just like, benefits versus risks.
We had to do something. We were definitely in the experimental phase of all that. Physicians didn't know what to do. Look how quickly the protocols changed. It was like every week there was something different, something new.
Yeah, speaking of that, it was wild how you had patients on Vapotherm, and they had to get downgraded or just like, hey, let's aggressively wean them because we have to get this patient out. We have to make room. It is what it is.
Or we have one BiPAP left.
And
Let's use it properly.
And then the doctor's like, well, there's going to be a lot more harder decisions we have to make. So it is what it is.
Yeah.
I'm just like, wow, this guy just really set. That's what set the mood. I'm just like, this almost feels like war.
Or it's like
casualties.
Yeah, or it's like we have 2 vents down in ER and we have 2 more here in ICU. That's all we got. It's like the whole hospital's like shit. We have 4 vents left.
COVID was a crazy experience.
Yeah, and you gotta have 2 in the ER. That's crazy, man.
So speaking of wounds, also like tunneling. Tunneling on these wounds when these wounds are larger than we think. And you just like look, you have to like pack them. Sometimes you take the Q-tips and you pack them around and you try to like get as much in there because that promotes healing. That's nasty, especially the smell. These masks that we wear don't really protect us from the scents.
No way.
I don't want to even say scent, it's a smell.
Yeah. And the reason why you pack these wounds is because you want to promote wound healing from the outsides going towards the inside. Because if you don't promote the wound healing, you're going to get like abscesses and it's not going to heal properly. You're going to get infections. So that's why we pack these wounds and tunneling. That's why it's important to do these. Don't just ignore it. You actually got to try and pack it fully because you're not going to promote proper wound healing. And then if one nurse is doing it properly, the other one's not doing it properly, guess what? You're pulling off good tissue when you're changing that kind of dressing.
Yeah.
That's why I brought that up because I see that a lot. I see that sometimes I take out some packing and it's just like I use double or triple what that nurse used. I'm just like, how does this happen? You know?
Yeah, you have to pack it properly. And then when they go down for these wound debridements, these wounds are a lot larger then, and they bleed a lot more because you have to get rid of the tissue that's already necrotic and scarred and it can't heal. You strip that away so fresh skin can replicate it and heal. Those wounds are bigger. I remember packing patients like it was like literally half a butt cheek down to the thigh. We're just like doing this packing. This was in Hinsdale, and these nursing home patients were heavy. They had one of like the crazier LTACs from around the area, always vented, trach, just came in for these wound debridements and just like sepsis because of that.
Yeah.
Nasty.
And it's crazy how they stay alive. Was there a family that came to see the patient?
Was sometimes. And the family's there in the room and they feel bad, but I don't think they ever maybe took like a look around and see how bad that wound is.
Yeah, probably not.
And I wonder, there's nothing, I understand you're trying to promote somebody's life in the Western culture, but it blows my mind how we don't understand that, yes, this person is alive and that's great, but the amount of suffering that these patients go through. And we had an episode, we talked about how hospice care gets delayed. And at the end of the day, it just causes more pain and suffering for not only the patient, but also the family. And
it's like,
we still do it with improper education.
And it's, are they even alive? If you have a patient that's non-responsive, non-verbal, post-massive stroke or post-massive MI or debilitated through disease, and they can communicate and they're not getting any kind of response, but they're living, like, are they actually, like, anything going on in their mind? Because we could think and all that, but how are they in their mind? Is there anything there?
Yeah.
And that's why it makes it difficult, because we don't know. And we don't really know how to, we don't really know how to find out either.
That's why nursing is not black and white.
That's the dilemma. It's interesting, man.
Yeah, the last one we're going to talk about is poop. So as you know, poop is nasty. I still prefer it over respiratory secretions. And that's the code Browns. And it's funny how when you usually get patients in the ICU and wherever you admit them, every single time you turn them, that's when they tend to poop. A couple days ago, had a patient admitted, turned her one way, started pooping, had, hold the chuck, cleaned it up, flipped you on the other side, clean chuck, boom, goes again. And that's the poop phenomena that happens all the time. It's like these patients just get stirred up and you start shitting, especially when they get admitted.
And I'm glad you brought that up, because now it has me thinking, what if there's a study out there that shows how turning patients Q2 hours promotes like fecal excretion? Right? It seems legit, because I feel the same way. There's been a handful of times where I turn a patient, like a patient hasn't pooped in a while or trying to poop, and I turn them and it comes out.
Yeah.
That's all you had to do.
My theory is something with peristalsis.
Yeah.
When you're turning the patient, they get scared. They think they might fall. So they're like, oh shit, and literally, oh shit. And then they tend to poop because they go into fight or flight and they have this crazy neurological response.
Makes sense.
maybe you stimulate some kind of senses and then you just go. That's my theory.
That's a pretty good theory. It seems legit, man. Hey, you heard it here, folks.
Yeah, and also like I remember when I was younger, beginning nurse, I had a guy that didn't want to use the bedpan because it hurt his body. He didn't want to get up because he had one BK and he was too lazy to use the bedside commode, even with his like, the prosthetic. So he wanted me to just turn him on the side and he could just shit.
No way.
So I grabbed the towel, the small little towels, and I held my hand by his ass and he shit in my hand.
Oh my God.
I know.
Holy
Yeah, sometimes nursing scars you literally.
Oh my
And
God.
when I was younger, and I had this, it was less than 6 months as a nurse. I'm like, what did I get myself into? That's what was going on my hand.
Yo, low-key.
Going on my head, I should say, while I'm doing that.
I'm sorry, but if I would have had that patient, I would have been like, no, I'm not going to turn you on your side. You're going to either go on a bedpan or we're going to get you up into this commode. Because, man.
So that's why I was a beginning nurse. And
that's
I didn't know how to set
crazy.
boundaries with my patients.
Yeah.
So these patients could step over you.
That's interesting. Yeah, you're probably like, I'm never doing that again.
I've learned the hard way.
Yeah.
Yeah, poop is...
Even if they have a flexi or rectal tube, like that stuff still smells. Like, yeah, it goes into a bag and stuff, but you have to empty that bag. It's nasty. Or people that have ostomies, that's still rough.
Ostomies still disgust me as well.
Especially the ones that like just the dressing doesn't want to fit properly, or bag doesn't want to fit properly for whatever reason. Maybe it's like a abnormal area, or they have some abnormal body features where the bones are a little bit different than normal, and their tissues are a little different areas where you can't just clip it on properly or stick it on properly, and it's always leaking. That's the worst too, man.
Yeah, and when you empty those bags, that's nasty. Rectal tubes. I had a couple of days ago, I had a patient that had a fecal management system in, and PT and OT got him up because they had to move him around. He's been in the ICU for 10 days. He's in his 40s. He needs to get up. As soon as he gets up with that fecal bag, it just starts leaking, and he just starts like leaking diarrhea. And he had C. diff too, by the way. Excuse me. And it just smells. It's all over the floor. It's on his socks. Remember the last day when I was in the previous contract in Cali? I had that patient. I was ETOH. Kept getting out of bed, and she kept shitting herself. She shit three times on the ground. And I remember she was also positive for TB.
Yeah, so you had to wear the whole pamper.
So I had to wear a pamper, and all you see is nurses like through the window just looking at me like, "You good? You good with the thumbs up sign?" Like, "Yeah, I'm good." And I'm surprised she didn't fall that night. She was so out of it.
That's so funny. Imagine, guys, walking through a room with like a regular sized window, and you just see Matt standing there. Next to Matt, you see a patient, or you see Matt with a pamper, first of all, with the whole thing in it, with the whole box in his pocket.
You see my face, like, just not happy.
Sweaty, red, because he's been there for a minute. And then you have a lady standing on a towel, standing up and shading herself. And you see the shit dropping with Matt standing over there. And I don't know what the hell is going on. And he's like, I'm good.
And that patient, I had to clean the whole bed multiple times. Sometimes I went on the chair. The third time, she actually squatted down and then she shit on the floor for me. At least she shit on the floor. It was easy to clean up. It didn't go over body. But it's like, then you get this patient back in bed. You got to wash her feet. It's just poop everywhere, man. You got to use the bleach wipes because the floor smells. And that's the real part of nursing, that the patients you might get. And you're a travel nurse. Let's just add that into the pot, where more than likely you're going to have these patients. Yeah. And that's why I remember that guy, he got upset. Yes. He's like, why do I get the travel nursing assignment? Yeah. It is what it is, bro.
Yeah. That's funny when that guy said that. Because the first thing I thought, because then he brought up like the money that we get. He said,
he was being an asshole to us.
They get paid the big bucks, so they should be dealing with this kind of stuff. He said something like that. I mean, we didn't say anything. He's going to be rude, but I mean, he could be a travel nurse just like anybody else.
I swallowed my pride at that time.
I was like, it's a nice place to work at. I'm not going to start a problem. I'm going to do my job and move along. Yeah.
Let's wrap this one up. Hope you guys enjoyed these bedside stories of the nastiest and grossest parts of nursing when it comes to vomit, poop, blood, feces, all parts of the areas or the bodies, wounds, you name it. Nursing has it all. It's fun.
As Matt always says, thank you for your time. Give us the like, give us the stars on Spotify, give us a rating. If you really enjoy our content, check us out on YouTube. We got some cool stuff on every platform.